Dr. Peter Evans. And first, I would like to welcome our chairpersons, Professor Veena Jain ma'am, who is head of the department prosthodontics at All India Institute of Medical Sciences, New Delhi, having more than 25 years of academic research and clinical experiences. She has contributed immensely to the specialty through 12 funded research projects as a principal investigator, 60 Medline Index publications, course mentor in 20 clinical workshops, and member of editorial board for 6 journals. She is also a fellow of International College of Dentists and has held membership of Indian Dental Association, Indian Prosthodontic Society, and honorary member of PG Board of Studies at different universities. So I would like to welcome Professor Veena Jain ma'am. And the second chairperson is Professor Swati Gupta ma'am. She has completed her BDS in 1998 and MDS in 2001 in King George Medical University, Lucknow. And presently she is working as a professor in BBD course, Lucknow. I have done most of the clinical work under her guidance only. So I would welcome both of my chairpersons. Ma'am, there is no video for that.
Yeah. That was so nice of you to say so, Shuchi. Shuchi completed her graduation from KGMC in the year 2004. And then she went on to complete her post-graduation in prosthodontics from Subhati Dental College, and that she completed in 2008. Currently, she is working as additional professor in the Department of Prosthodontics, KGMU, Lucknow. And for today's webinar, she's the moderator. Thank you so much.
Thank
and
you,
welcome, a very warm welcome to all of you.
Greeting to all.
Thank you, ma'am. It was such a nice introduction for me. Hello, ma'am.
Invite Veena to introduce the speaker. Veena? Yeah, please.
Yeah. Greeting to all. In today's evening, we have Dr. Peter Evans with us. He is a healthcare consultant in reconstructive science and maxillofacial prosthetics. Peter trained in London and gained experience with Keith Thomas at St. Andrew Hospital, Billericay. After gaining his maxillofacial qualification, he worked at the Middlesex Hospital, London, and St. John Hospital, Chelmsford. In 1989, Peter started at Senior Maxillofacial Prosthetics at St. Lawrence Hospital, working with maxillofacial surgeon. And then Sugar and his team. This was to insert craniofacial implant in the UK. In 1998, the craniofacial team relocated to Morriston Hospital, where he is now head of the 16-person maxillofacial laboratory, providing the Wales regional services in the prosthetics, surgical planning, advanced therapies. Professionally, he is a secretary of the Advanced Digital Technologies in Head and Neck Reconstruction and head of training for reconstructive science. He was recently awarded fellowship status by the Institute for Maxillofacial Prosthetics and Technologists. About the Peter, when not working, Peter is a keen artist and gardener with a small holding in the Swansea Way. I heartily apologize for any mispronunciation. No. Yes, please continue.
Okay.
No. I would like to welcome Peter Evans for the presentation. Hello, sir.
Hello, thank you very much. Nice to see you all. It's 11 o'clock in the morning here. It's quite, as you can see, the sun is coming in, which is very unusual in Wales, although it's only about 10 degrees outside. So,
that's very good.
So I'm going to talk to you this morning, or this afternoon for you, about facial prosthetics. We'll go through quite a few. Different types of prosthesis, And I'll show you some of the analog techniques that we use, and then we'll go and look at the at some of the digital techniques as well. So just go to the next slide. Okay, so let me just move you. So we have, we're going to start with auricular prosthetics design, and then analog and some planning. And then we look at digital nasal design, and then we'll move on to orbital prosthetics. And then finally, we'll look at breast prosthesis design and manufacture as well.
Wow,
that's a good result for us, and that's what we're looking for. That's what we're looking to achieve, to allow for a prosthesis to be manufactured without compromising on the detail or on the aesthetic carving. So everything is, in the end, has ended up in the right place. The only way you can do that is by good planning. And when we first started the program, we were analog planning. But now we can digital plan. We can make our results.
Online activity.
Who is this? We can hear some sounds. Please, can you all be muted?
So,
Please mute yourself.
So we some young people joining. So we have, this is our Mimic software. This publication that we first that we did goes way back, actually. I think we did this with Alan and Adrian Sugar back in 2003, using the Mimic software to plan our surgical positions. And you can see in this slide how important that is to plan accurately, because as you can see, it wouldn't have taken much for us to have to move our implant positions. We've got them in the ideal place there by planning, but you've only got 2 or 3 millimeters of bone. If they'd been a couple of millimeters lower, you can see that they would have probably gone into an air cell. So you can plan very accurately if you used CT scanning with guides. So in order to plan, once we've planned in Mimics, we export those implant positions into our freeform software, and you can see that in the top there. And then we mark out the area for the guide. We try to keep our guides relatively small so that the incision can be kept, and the flap that's raised can be kept small. But you do need to look at some of the areas that you're going to, because it's quite a flat. You want to key into some of the anatomy there, but you do have to be careful, especially on congenital cases. You don't come too far forward because of you might hit the facial nerve. And this is the basic design for the guide, and then finally that's finished then in free form, and that's relatively quick. You usually do that in probably an hour and a half really to design your guide. So you can either get this then printed in a plastic, or as we prefer to do now, is print them in metal guides. And back in 2010, you can see the image on the left there. This is a quite a thick metal guide, but they worked really well. But you can see the finish is not that fine, and they were probably, as I say, 2 millimeters thick. But on the right hand side, you can see that the guides that we get now are 0.5 millimeters thick and much easier to use. So you can see here the guide in position on the temporal bone and on the mastoid bone. We don't use the guide to direct the drill as you might with a dental guide, because you're only drilling down 3 to 4 millimeters, there's not much point really. We're just using it for position. And on here you can see in another case the guide in place, and just to go through the procedure, you can, I think this is slightly in the wrong order, but if we'll go back, you can see mark the holes, and then we drill, and then place the implants, as you can see here. And these are the newer cochlear craniofacial implants. So then the flap is replaced, the skin pierced, and the abutments placed, and then the dressing on top. And the dressing is perhaps the most important thing, because you need to push that skin down around the implants, so that you get a nice tight skin around the fixtures. And the reason for that is that if you have thick skin, you're more likely to get infections and constant minor infections around the implants, which you may not lead to the loss of the fixture, but certainly will be a pain for the patient, because they'll always have some sort of low-grade infection there. And so what we try to do is not just use this digital data just for planning our implants. We can use, because when you import that CT, you've got soft tissue and hard tissue data. We can use that that data that we used for planning to manufacture our prosthesis, so that you make the whole procedure and your final result a lot more predictable and get better results. So this series of slides will just take you through how we manufacture an ear prosthesis on analog. This is a trauma case, and we placed 2 craniofacial implants, 2 4mm fixtures, and on here we have maxi magnets, 2 maxi magnets. Each of those has a 1.5 kilograms pull. So you've got 2 options. You can either use magnets or a bar. We tend to use bars in younger people and magnets in older people. So, and here we've put on, in the second image, we've got our impression analogs. They've just been clipped on top of the magnets, and then we put a small amount of impression material. This is actually bite registration paste, which is the hardest of the impression materials. We just put that on first, just to make sure that you fix those impression copings into the impression. So next step, we use quite a nice thixotropic impression material. Doesn't really matter what you use. I think this one's from Technovent, and it's nice because we can keep the patient in the upright position. They don't have to lie down. You could alternatively do this with alginate as well. And then on top of that, because if you took this off now, that would be quite floppy, we add, this is again bite registration paste on top, or you could just use a heavy bodied impression material just to give the whole impression some support. You then remove that from the patient, and you can see your impression analogs there, and we put copings in there, sorry, lab analogs into the impression, and then pour that in dental stone, as you can see there. So when you pull your impression off, you'll be left with the impression that you've got here. And then we need to make our substructure, what we call our base plate for the ear. So we apply a thin layer of wax, 0.5 millimeters, just to make sure that the base plate doesn't sit onto the skin. And here on the center one, you can just see our auricular magnets there that have been put on, and then our base plate on the right-hand side. We tend to use a light cure resin for our base plates, because one of the perennial problems has been of base plates pulling out of prosthesis, acrylic not bonding to the silicone. And we found that the light cure silicones have less free monomer in, and that does seem to bond better with a primer to the silicone. So here we're, from then on, really, we put that base plate, we try the base plate onto the patient. and then we start working on the patient with our wax carved ear. Now this might be hand carved, or it might be 3D printed and then copied into wax, and I'll talk about that in a little bit. But we are working directly on the patient then for the rest of the procedure. So you don't, from this point on, you're not returning to a plaster model. The reason for that is that an ear edge is dynamic. If you want that ear edge to stay in position and to be nice and thin, you have to do these procedures, this part of it, on the patient. We've not found a way around that. So next, once we're happy with our ear on our patient, we remove it and we start to do our moulding. And you can see here is step one of the mould. We put a base on there, and that also allows us then to do our final detailed carving. We might spend sort of an hour or so doing that, putting that final detail in. And the next part is we're going to make a 3-part mould. So you've already made your base, and you can see your analogues are in the base of that plaster there. And then we're going to make what we call a frog, which is the helix portion. This sits behind the ear. And then on top of that, we're going to put another layer of plaster, like so. And this will give us a 3-part, as you can see there, a 3-part mould. So when that plaster is set, we will then boil away the wax and open up the mould into its 3 constituent parts. And then we can start our colour matching. So we will use a liquid silicone. You can see here, these ones are pre-coloured. We've found that the pre-coloured ones seem to have some better colour stability. Saw a patient yesterday who'd been wearing an ear prosthesis for 2 years, and actually the colour was still very good. So the pre-coloured ones that we use do seem to have a better longevity. And then we're painting those colours into the mould. In effect, you're working in reverse, because this is the opposite, this is the opposite side. So you are sort of trying to work in reverse. But if you hold the mould up to the patient, you are seeing the same shape there that you would that you're seeing on the patient's ear. So obviously, what you're copying is the patient's remaining ear. If it's a bilateral case, and it may be a congenital bilateral case, you would have to just pick out the colours that you see on the patient. So you might start with some of the base colour from the neck, and then the helix colour might come from the cheek. But most of our cases are unilateral. And this whole process probably takes about an hour, 45 minutes. And then you can see that we've painted all the colours into the mould. Hopefully they're going to stay in the same place when you squeeze the mould together. So here we've closed the mould up into its three parts, and then put it under a press and that stays under there for about an hour. It takes, we cook it around about 90 degrees for an hour, hour and a half. But that must be done under pressure, otherwise you'll get porosity. It's similar to an acrylic resin. And then hopefully when you open it up, you get something like this, as you see on the left-hand side. And when you're looking at this, the key here is this front edge, because that's going to blend into the patient's skin. And so you don't want to tear that when you're taking your ear out of the mould. And here is the final ear prosthesis, and on the reverse you can see the magnets. And these actually have a little O-ring on them as well, a little rubber O-ring, which also gives them a better retention. And then we can then try it onto our patient. We may do some extrinsic coloration, so just surface coloration, just some freckles or just slight adjustment of the colour. We try to keep that to a minimum because we're aware that those extrinsic colours don't last as long as colours that are actually packed into the mould. So we try to keep that to a minimum. But generally, it just takes, you want to add a few little bits of detail, maybe a little bit of shine to the concha to give it to that waxy look. But now is the time to do that. And that's our final prosthesis. You can see the fine edge there blending into the skin. So you can see we've added some extrinsic color just to give that, to blend that in. So those, I wanted to go through that because really for you to understand that that traditional facial prosthetics is quite a long-winded and quite time-consuming procedure. And we've worked with Dom for quite some time, really, with Professor Egbeer, looking at how we can include digital technologies to reduce that that work. And we're probably still, I think, at a transitional stage. So although we are using digital technology, we're actually increasing the stages in our production. So we can scan, we can mirror, we can print a duplicate of prosthesis, which is then duplicated into wax, etc. And we can make a mold. But ideally, in the future, what we're looking to do is get into a point where we scan, we mirror, we design, we print the mold, we color match, and then we fit. And that's where we need to be. So at the moment, we're in this transitional phase where we're actually adding stages, but it does make our results a lot more predictable and a lot more aesthetic. And there's various, there are various things that you can use, technologies you can use. This is a 3D MD scan, sadly of myself. You've got model scanners this is a Roland scanner. We've got a 3-shape scanner now. You've got CBT data that you see here, and you've got your full CT data as well that you can use. And all of those will give you soft tissue detail. And this is one of the examples that you can do. This is this is actually a printed wax ear, one of our early cases. So we were working closely with Dominic in the early days, and they could print in wax. And sadly, that's not a facility we have anymore, but it did allow us to then try that wax ear onto the patient. You can see the pink wax on the front edge there, which is what we added to get that final fit, and then the final prosthesis on the right-hand side. And we also 3D printed molds. I'll talk a little bit about that later on, but essentially it's not something we do every day at the moment, but I think it's something we've got to move towards. It is the 3D printed molds, but this did work very successfully and produced a nice prosthesis. And this is designed in freeform and printed in SLA resin. So moving on to nasal prosthetics, we've got, this is, again, getting this edge is critical, and getting your color right is vital really for making a nasal prosthesis. But noses are more difficult than eyes and ears because you haven't got anything to copy. And that's always been the challenge to us. In the early days, patients would just turn up. They may have been treated at another hospital and already had their anectomy. Most people don't, and they turn up with a small passport photo of how they used to look. And most people don't have pictures of their side profile. Nobody likes their side profile. So you don't, as a prosthesis, you don't have a lot to go on. But you can use your digital planning data. This is how we normally treat most of our nasal patients with zygomatic implants. We found these very successful. We don't lose very many. Your osseointegration is away from the site of radiotherapy if there is post-operative radiotherapy. We used to use 3, but we generally just use 2 now in most cases. And with the maxi magnets, they give very good retention. On clinic yesterday, we saw 2 or 3 cases that were long-term cases that were doing very well. So if you're going to use such a long fixture, along zygomatic implant, you have to have guides to guide those fixtures in, and these are designed again in free form. These wouldn't be printed in metal, although we have done some in metal, but generally we use plastic guides, SLA printed guides, and then we put a metal furrow in there just to guide the drill. And depending on where the resection is going to be, sometimes we'll do an anterior guide for the bridge of the nose, and sometimes we'll do an inferior guide on the base of the nose if, as you can see in this case, the tumour is more superior. And on these lower images, you can see the guide in place, and then the fixtures there. And these are the healing caps in place. And usually 4 to 6 weeks post-operatively, you can start to rehabilitate the patient. So as I mentioned, noses are rather difficult to carve because you've got nothing to copy, but we do have the pre-op data from our CT scans. And most tumours are unilateral. And so only one side of the nose becomes distorted. So you can use that remaining side to give yourself a pattern to work from. So here what we've done is we've put a mirror plane down on the unaffected side of the nose and mirrored that across to give you a good nasal shape. So the next sort of images I'll show is on some research work that Dominic did, really on using and taking this a step further and using freeform to design the whole prosthesis. So you can see that here. In this case, we were looking to see what was the minimum that we could do with the patient. So we brought the patient in just for one scan. And then the rest of the time, all this work was done by Dom on freeform. On our previous cases, we'd noticed that we weren't getting the fit that we were when we did the prosthesis in wax, because when we're working directly on the patient, you do get that pressure of the wax against the skin. But when you're working digitally, everything is passive. So we had to create some sort of pressure on the patient's skin so that the edges, when they're nice and thin, blend in. And Don did this by removing different layers of varying thicknesses as you graduate out here. So each of those colours represents a different amount of material that's been removed from less to more. And here's the prosthesis that Dom has done, and I'll just go back a little bit. We're also then able to, from that, create a mold. So rather than the plaster mold that I showed you earlier when we're doing the auricular prosthesis, we could in fact design and print a two-part nasal mold that you can see here. And that has several advantages. Firstly, it's repeatable. The plaster molds that I showed you will probably last around about 5 prostheses. Because they're heated, they will break down eventually. But if you can print in a good thermally resistant material that are available now, that will allow you to if the mold does break, to reprint it. Or you could even save on storage. So we've got a large storage room full of all our molds for our patients, but we could do away with that if the whole thing was digitized. The other advantage of printing a mold is that you can print in a clear material. So as I mentioned before, with the auricular prosthesis, I was holding the mold up to the patient's skin and working in reverse. But when you work in a clear material, as you're applying the color, you can actually hold that up to the patient's face and see where you're applying the color, which has a huge advantage. Digitization of the technique could really bring some bonuses to us. And this is the final prosthesis. which is, I think it was Dom's second prosthesis, and you know, a really good result, considering that we only saw the patient, I think, once or twice. I think we did final extrinsic coloration and the first scan. So in this time of COVID, where we're looking for less patient contact and bringing the patient in less into the secondary care environment, there are some real bonuses to using digital technology like this. So the next couple of slides really shows what the technique as we're using it now. The previous ones were really about a research project, but this is really what, in reality, what we're doing, and we're probably mixing matching techniques. So what we would normally do now with a nasal patient, once they've had their implants and they're fully healed, we would take them through our 3D surface scanner, and that would give us the image that you've got there. Now we find that the accuracy of that surface scan isn't quite enough for us. So what we do is we take an impression of the patient's nasal area, and we scan that in our model scanner and bring that in and match that in with the soft tissue scan that we've got. And then we can take in the nasal pattern from their CT scan and position that on the patient. So essentially you're putting the patient's original nose back on. You're not making anything up. You can see that inside profile. And here you can see the prosthesis design, digital prosthesis design from the back and the front. You can see here where our magnets are positioned as well. So then we printed this in a simple, just a PLA resin, a cheap PLA resin. I say it's probably cost is probably less than £2. And what we've done, we do need that fit onto the patient's skin. So we've added a wax edge around there so that that can be blended into the patient's skin. We're still using traditional color matching techniques. There are colorimeters and some coloring systems out there, but they only give you a basic shade. I think for the time being, until we can actually print in silicone, we are limited to using an analog technique for packing the mold. But here is our workflow. We've got the nasal shape on the cast in free form, printed in PLA, and then fitted to our patient. And we found that we're getting far better results using this technique. So just go through a couple of cases, nasal cases. This gentleman, you can see quite a large tumour. Actually, it was it hadn't infiltrated too far into the soft tissue, and the nose was resected. This was one of our first or second zygomatic case. You can see there, and then that's his nasal prosthesis, again taken from the CT scan, and you get a nice result. We could also use it for more complex cases. This is in this case we've got zygomatics, but the patient had also had their premaxilla removed. We managed to get one fixture in, but what we could do then is design the prosthesis so there's a denture that connects to the nose with a substructure, and then you've got your final prosthesis there. So that's his denture going in, and that links with this acrylic substructure to the prosthesis. And that's quite an old case. That previous case is quite old. It's probably about 5 or 6 years old. But more recently, what we're doing with these cases where you do have a missing premaxilla, and the only implants you've got are your zygomatics, we're milling a titanium bar. So in this case, we've got 2 maxi magnets that screw into that cruciform bar shape. And on the bottom here, there's what they call a large multi-purpose magnet that goes in here, and the obturator then attaches to that. As you can see in the right-hand image there, there's the bung of the obturator clicking in, and that gives a very stable base for the denture to fit onto. And then, but you haven't lost anything because you can then put the prosthesis on top of that. So, turning to orbital prosthetics, which are always a challenge. Really because of space. We're trying to do a lot in quite a small space. We've got to get an eye unit in here, we've got implants, and we've got a substructure and magnets to get into a relatively small space, and that's really the challenge. So planning here is essential, digital planning is essential to get these implants in the right place. And we try and actually digitally design the prosthesis as well, so that we can see what the impact of those retentive elements are going to be. Because you can put the implants that you can plan to put them in the bone in the correct position, but then when you put your abutments on top and then your magnets, they come quite far out, and that can be quite difficult to get into the final prosthetic design. So for orbital patients, we have done some digital work, but this is how we would work on an analog basis. For orbits, I quite like to work in clay. So we've got a wax base plate, and then we're carving in plastiline clay, because it just makes everything quicker, and the carve lines that you get are just more natural. So here we've taken it off the patient and we're putting in our final detail, and it's on our base of our mould. And this is the mould boiled out. You can see the substructure and the eye in place. So we make two little divots in the back of the eye so it locates in the mould. And when the patient returns for a second prosthesis, what we'll do is we'll take the eye out of the old prosthesis, we'll make a new base plate in the mould, put new magnets on here, make a new base plate, and then repack that mould with silicone. And as I say, the plaster moulds probably last around about five prosthesis before they start to break down. So here we're packing the mould with silicone, ensuring that we get silicone under the eye. So because you don't want air blows in there, and this is our liquid silicone on the palette. It may look rather ad hoc, but it does all end up in the right place, hopefully. And this is our final prosthesis once we've opened up the mould. You'll see those fine edges that are going to blend into the patient's skin, and they're really key to any prosthesis. Sometimes you might make a rolled edge, a butt edge, when you can key the prosthesis into existing patient creases. But generally, you're going to need a nice fine edge to blend into the skin. And there's our finished result. We always, whether the patient needs glasses or not, we always advise that the patient wear glasses for two reasons. One, they just put that barrier there. The eye doesn't move, so if you have a slight tint on the glasses, it just takes that stariness away from the eye. And the edge of the spectacles do as well hide the edge of the prosthesis if it's visible. And also, they've only got one eye. They've lost their depth perception. So a pair of spectacles also protects their eye, so that if they're walking, in the forest or somewhere, and there's a low-hanging branch, because they haven't got depth perception, it protects the eye from getting injured. So lastly, we come on to breast prosthesis. So as maxillofacial prosthesis in the UK, we do cover not just head and neck, we cover the whole body. So we do nipple prosthesis, breast prosthesis, fingers, toes, even small leg prosthesis. So we do cover everywhere. We started some research a little while back because there was a need for better, improved breast prosthetics. First of all, you know, when you work on the face all the time, you think, well, a breast prosthesis is under a bra, it's under clothing. Is there a huge issue? But breast prostheses are very important. They help with the body asymmetry, the self-esteem. The prosthesis weight, it helps with the patient's posture and prevents curvature for the spine, etc. Current off-the-shelf prosthesis, the ones that are provided to our patients that go through, are not particularly good, and you can see the variety there on the right-hand side. So when we were asked to make a custom breast prosthesis, it is very time-consuming. You can imagine taking a large impression like this with plaster bandage. That's time-consuming and not particularly pleasant for the patient, and also it's quite inaccurate. The reason for the inaccuracy is that the breast in the bra is actually a very different shape to the breast naturally, and so even if you do take an impression, you don't often get what you set out to achieve. And then also working on quite a large model, the sculpture is quite time-consuming. So that was something we wanted to avoid. And then if you imagine the mold for a prosthesis compared to a plaster mold for an ear prosthesis, it's quite large and cumbersome, and that was also something we wanted to get rid of. So we've got a 3D scanner, fortunately, in the hospital, and this is a 5-pod system. Torso system, and you need that 5-pod because you want to capture the mammary fold. With a 2-pod system, it just doesn't give you the detail that you want. You don't need particularly high resolution, but you do need to capture the curvature of the breast. And I think this is the Structure Sensor 2 Mark II that we used with yourselves out in beginning of this year, that Dom's using here, and I think when we've looked at this is quite adequate for breast for making breast prosthesis. I'm not sure it's accurate enough for facial prosthetics, but certainly for breast and body prosthesis, it works perfectly well. And this is far more portable and far cheaper than the 3DMB system. So when you take your image, you've got to be careful on the positioning of the patient. There's several mistakes in this scan. Firstly, if you look that the patient's not facing forward, they're looking slightly to the, I think it's their left or their right, can't figure it out. And also we haven't quite captured the navel. Which means that when you put a central plane down the patient, it's quite difficult to position that plane because we don't know where their point of symmetry is. And on the right-hand side, we also can see here that we haven't quite captured under the arm, and that's critical for the prosthesis, as you'll see later on. So this is a better scan. Here we've got good symmetry. We've captured the patient's navel there, so we know we can put that center line down through their chin, through their philtrum, and we know we get a good line of symmetry. We still have to be careful how we angle that plane, but it's far easier if we've got those anatomical landmarks to work from. And also we've been able to capture right under the arm where the prosthesis is going to fit. So here's our scan as we take this through our work process. You don't get this much detail with these scans. You can see every single freckle, etc. here, but you don't really get that. This is just a wrapped image over our soft tissue, but we don't need a huge amount of detail for these. So we take 2 scans, one of the patient without their bra, as you see in the previous scan, and the other scan is with the bra on. As we've gone through this process, we've learned a lot, and I've learned a lot about bras that I didn't know before. They do need to fit properly. It's no good starting your prosthesis process with an ill-fitting bra, and so you do need to have this fitted properly, and because it's going to hold the prosthesis. Although you can, once you've got a good fitting prosthesis, can be changed from bra to bra, which normal prosthesis can't be. So once we've taken those 2 scans, we can then, moving forward for some reason. There we go. We then we take them into free form and we combine the 2. So what we're trying to do is get the shape of the breast and the bra on the unaffected side, and then we can mirror that across to the affected side. So we put a mirror plane in, we select our area that we want to mirror, put our mirror plane in, and then mirror that across to the other side, which is quite a simple process. There's quite a lot of debate. We talk with the patient quite a lot about how we're going to extend that superior edge onto the chest. That often can come above the bra, but we can't go from a prosthesis to nothing, otherwise you will have a dip. So we do talk to them about that there's going to be an edge that you will see above the bra, but we can flesh color that so it blends in better. So, and then we've got our final design, and you can see how that fits. I think I've got another image there. And this is the critical part, because most all off-the-shelf prosthesis will not fit under the patient's arm. And so they always, especially for the larger breasted woman, as the prosthesis gets larger, the prosthesis also becomes wider, and they're very uncomfortable. But with the custom fit, that will fit nicely under the arm and be a lot softer and a lot more comfortable. And this is our final prosthesis shape in free form. And then really it's just a simple matter of exporting that through to your slicer software to be printed. And this is one of our old 3D printing machines. I think this machine was recommended by Dom, actually. I blame him, but it was a fantastic machine. It works, it worked, I think it was about 400 pounds, and quite easily managed to print our breast prosthesis. We have upgraded now to a larger print bed and something a little bit more reliable, but certainly for the investment, they'll print in PLA the breast prototype, and that's all you need is a breast prototype. So we take this prototype, we remove all the supports, and then we try that onto our patient and make sure that is going to be symmetrical, is going to fit the patient well. We don't always get it right, to be honest. I think I would say 1 in 3 patients we end up going back and redesigning. A lot of that is to do with the shape of the bra, and also that the patient hasn't been orientated in the scan perfectly. So sometimes we do, but it's a relatively simple process, and these are quite reasonable to produce cost-wise. So I think this is one area when Dom and I started working together, we were 3D printing the molds for the breast prosthesis, and we've just found that probably just cost prohibitive, and we've had to revert to plaster molds. So these are quite bulky, but they are cheap to produce and reliable. Our ultimate goal would be to go back to printing the mold, because these weigh an absolute ton and they take up a lot of space in our storeroom. But they are effective. So here we've molded the prototype, and then it's just a simple matter of removing that and then pouring silicone foam into the mold and closing it. So this is our mold here, a 2-part mold. And this is our resulting foam prosthesis. This is one of our earlier ones, and often we do just a simple one just for the patient to try on, see how they get on. We normally provide them with 2 prostheses. So this is in silicone elastomer foam. And this is one of our newer ones. In fact, this is going to be fitted on Friday. So this is the foam. So what we've done is we have gone over to colouring the foam, because we did find that that top edge that shows from under the bra can be seen otherwise. And also we've also, as you can see here, we've added a flange. And what happens is that flange just keys under the bra underwire and stops the prosthesis moving about, because these are much lighter than the silicone prosthesis that are provided commercially. So we found that if you just have that flange just to fit under the bra, it stays in place much better. But these are far more comfortable, and then they're just washed in a washing machine. You put them in a pillowcase and stick them in the washing machine, and they wash perfectly well. And our more recent ones, now we're also adding a silicone skin. So that's the same foam underneath, but before we add the foam, we paint a layer of silicone into the mold, which is colour matched to the patient's skin, and then you get a nice prosthesis. We can add a nipple to the prosthesis, but we only do that in some cases, because it very much then determines where prosthesis sits in the bra, so we only do that much later on. So these are some of or one of the results. You can see the prosthesis fitting here. This is the prototype in comparison to the final prosthesis, and you can see how that fits under the arm, and you get a good symmetrical look for the patient. So I think that's about it. 5 minutes early. Just to say thank you to all our team, and in particular Madhav Katur and Keaton Shah, who were our maxillofacial cancer surgeons. Adrian Sugar, who's now retired, but obviously a lot of the work that I showed were cases of his, and we wouldn't have the unit that we have without him. Lawrence Dobgalski and Steve Policy-McLean are my colleagues, and Richard Bibb, who started us on this role, and of course Dominic, who's been such a key player in developing the digital technologies with us. Thank you very much.
Thank you so much, sir, for enlightening us. There are many questions in our chat box, and I would like to ask you one by one. So,
yes, certainly. Fire away.
So first, what are the current challenges and limitations of the ideal workflow?
I think I think when we started out, you can gain a lot from using digital technology. You can gain a lot. You can improve your predictability, and you can save a lot of time. It's where you use those digital technologies in your workflow, and not just using them for the sake of using them because they are improving your treatment.
Mm-hmm.
So, did that answer your question, or was it?
Actually, sir, the other is what type of implants you are using for the external or internal hex?
That's an external.
It's either the external or internal hex.
External hex. So yeah, that's it.
So what is your views for that? For the external hex?
We haven't found a problem. You've got to remember, these implants aren't under the the stresses and strains of dental implants. The forces on them are quite minor. We haven't had any issues with the external hex. We have had some issues in some of our patients who were done a long time ago, and we've been doing this for over 25 years now, and some of those patients are coming back, and we've had screw fractures and also some of the abutment screw fractures. But 25 years on, that's not too bad, really. I think they've lasted a good amount of time. But other than that, we haven't had any problems with them, so compared to an internal hex.
Okay, sir. So for the surgical guide, what material was used for printing?
They were done in titanium.
SL.
Early on, we were using, I think it was cobalt chrome, but the ones we use now, those thin ones, are printed in titanium.
So, okay. So one is for ear processes. According to your experience, which type of attachment works longer? And what about the patient satisfaction?
That's a very good question. I would say the bar lasts longer, but it's horses for courses. If you've got an elderly patient, it's quite difficult for them to hold the ear up and push it on. It's quite a force. Whereas if you've got magnets, with the poor dexterity, they can literally pull itself into place. If you've got a bar, it's far more. I think it's far more secure, and you can also improve that security by increasing the number of clips, changing the bar design, or even making the clips tighter. So you've got far more variability with a bar. But conversely, the problem with that is you don't know the forces that you're putting on the implant. So if we had a case that was perhaps had radiotherapy and we were worried about the implant survival, we would use magnets because we know the forces that are involved there. They're a lot more gentle. And so we would help hopefully improve our implant survival.
And sir, what is your views on use of magnets for auricular processes?
Oculars, definitely. We very rarely use a bar in the orbit because the lack of space. Also, the bar makes it, you've got to think about the patient long term, having to clean around that. They've only got one eye, so it's difficult for them to clean around a bar. If you use magnets, they're far easier to clean around, and also placing of the prosthesis is much easier. Generally, you find that 3 magnets, even mini magnets for an orbital, will hold it in place without any problem. You don't have the problems of displacement that you do with a nose, which can be displaced when maybe somebody cuddles somebody or goes to kiss them. They might displace their nose. And the ears, obviously, you take your jumper off, it can be knocked off, or you take your coat off, it could be knocked off. Whereas an eye is pretty secure behind the glasses. So we found that 3 mini magnets is usually enough.
Sir, which company silicons you're using? Brand?
We use Spectramatch, who are in Bath. So they're the pre-colored silicones. And they are more expensive than the ones you color yourself. But we're just finding that the color stability of them is just so much better that it's worth that investment, because the prosthesis lasts at least twice as long.
And the other question is for the durability, sir. Under climatic condition of your country, final processes, how much it lasts long?
Usually we hope to get 18 months out of a prosthesis. It does it is determined by the patient's lifestyle. If they smoke, you're not going to get very much. You'll probably get about 6 to 8 months. If I've got one patient who makes moves, so he's out in all weathers all of the time, and his ear prosthesis doesn't last particularly long. But generally, overall, for most patients, is around about 18 months.
18 months.
Yeah.
And so what will be around the cost of that prosthesis? Like how much the patient has to pay?
Well, they're free in the UK to the patient. Yeah, so that's quite nice. But I suppose if you were looking privately, it would probably cost around about £1,500, I suppose, if they were paying privately. But not most prosthetists in the UK are free at the point of delivery. So we would give them 2 normally.
So that's really good, sir. And there's some more questions. One is, do all printed prostheses are successful in terms of margin adaptation?
I think printed prosthesis.
Yeah.
I think that's the challenge for a printed prosthesis. If you, I think it's going to be when Dominic did his PhD research, he looked at the edge thickness, and it was literally microns thick that we were able to achieve from a molded prosthesis. And I think if you're going to 3D print in silicone, that is the challenge, is getting that thinness, because you've got to go down to microns to get any chance of that blending into the skin.
So, but I've seen in your all the slides, like margin adaptation is really well. It's really good.
Yeah, but they're molded, you see. So you're getting your thinness of your edge from the pressure of the mold. Yeah. Wow. But if you're thinking of printing them, 3D printing a prosthesis directly from silicone, which is almost possible now, as I understand it. The challenge is matching the thinnness that you can get on a molded edge. So
okay,
that's going to be the challenge.
And sir, how you have recorded the impressions using digital or the conventional? Or like
we didn't have a lot of success in recording digital implant positions, but we are looking now to getting an intraoral scanner, and I'm looking forward to sort of experimenting with that to see if we can use that intraoral scanner extraorally, maybe with some scan flags that you would screw into the implants and picking up the impression that way. Because the one thing about scanning, any scanning doesn't like anything shiny, and so by its very nature, implants are normally shiny, so they don't pick up very well. So I think it would be really interesting to see if the success that you have with intraoral scanning could be used extraorally. That would be some nice research, I think.
Okay, sir. Sir, please share your viewpoints on the use of digital spectrophotometer for shade matching. I think.
That's a good one.
Yeah.
I don't use one, but like all technology, all technology is a leveler. I think it gives people skills that they didn't have. So we do have lots of units around the UK who use a photospectrometer, and there's a nice system, I think, from either from SpectraMatch or from Technovent. I think from SpectraMatch, I think it is. There's a nice system where you scan the patient's skin and it gives you the formula to mix. You mix that formula and that will give you the base skin shade, which is probably the hardest thing to get. So I think, I think it does have its place, but we're making, I would say, when normally we'd probably be doing 4 or 5 prostheses a week. So we're quite adept at colour matching, and we've not seen the need for a digital tool. But if you're only doing one a week or maybe one every couple of weeks, then you're not going to be as practiced. So a digital tool could be really useful in that. So and they're relatively cheap.
Okay. Sir, one question is regarding the storage of the plaster molds. How much it lasts, whether for the 10 years, 5 years?
They last pretty well. We have seen some mold developing on them, mold on molds. So each mold will last, around about five prostheses, because you're heating them up every time to 90 degrees. The plaster gradually breaks down, and each time you pull a prosthesis out of a mold, you take away a little bit of that detail. So essentially a mold could last, if you're doing them every 80, if a prosthesis lasts 2 years, it's going to last 10 years, isn't it? So, which is a reasonable amount of time.
That's really good.
With children, we're remaking them more often, because as they grow, you need to make obviously larger ears as they grow.
Okay. So the best elastomers are also from the Technovent you have used?
Some of them what I've used are from Technovent for the base elastomers, and some of them for a company called Spectramatch. But I think Technovent sell the Spectramatch silicones, so I think they sell them. So, but we quite like the Spectramatch ones. They also do the ones I showed were liquid elastomers, but they also do a range of gum elastomers, which you use for a mill, which are quite nice as well.
Okay, so I think that's all of the questions now. Anyone else would like to ask anything?
Dr. Suchi, I want to ask one more question.
Haji ma'am.
I would just want to ask, sir, if from the Dr. Peter, sir, please, can you please clarify if we are printing the final prosthesis, we are making by 3D printing. So in that case, how to do the shade matching?
Yes, no, we're not at the moment. We're not 3D printing the silicone. We're still mixing our silicone by hand and packing into a mold. So the 3D part is printing a prototype, and then the prototype is molded in plaster, or you 3D print a mold. But as yet, we haven't found a way of directly 3D printing a prosthesis. It's very...
Still by the conventional method only.
Sorry, could you just repeat that?
Final by conventional packing only.
Yes, by conventional packing. Yeah. It's not quite there yet, really. It will come, but at the moment, it's not the same quality. There's been various research. I think there's some in Amsterdam at the moment looking at it. There was one big research program in the UK, up in Leeds, I think Leeds or Sheffield, looking at it. But nobody's really, as far as I've seen, nobody's come up with a way of 3D printing a silicone prosthesis of any quality, anyway. So,
thank you.
Yeah. I found it a new thing today that zygomatic implant can be used for nasal prosthesis as well. I had no idea on that. So thank you for this.
Yeah, we've been doing it quite a while. Simon Hodder did it first of all. I think he was one of the first in the UK, and I think in Salisbury, Mr. Tim Flood, he started doing it as well. And yeah, we've had a lot of success. All our nasal cases we do like that. Because actually there's not a lot of bone there really to access, and you might get some on the nasal floor, but quite often there's not much there. And also it stops you having to, most of our resections are subtotal rhinectomies. So if you want to put, some people talk about putting implants into the glabella, but then you've got to remove all that bone to get to the glabella, and actual implant survival in the glabella is not really that great. And also by doing that, the seal of the prosthesis around by the eyes is compromised, and often when you do that, they get, as they breathe, breath comes out, steams up their glasses, etc. So it's not very nice for the patient. So we found that by using the zygomatics, you can just maintain a subtotal rhinectomy and have good retention as well.
Yeah, that was really good. Swati, anything you need to?
It has been a very wonderful session. In such a short span of time, almost everything was touched up in detail. So very nice, and all the questions are very nicely answered. And for a beginner like me, I think it is a very good presentation.
Glad you enjoyed it.
Yeah.
Thank you, sir.
Thank you, Peter, for joining us today. And may I share my screen to present you virtually your certificate today?
Excellent.
So, hope you can see my screen.
Yeah. Oh, yes.
Yeah. So thank you so much. I will post it to you on your email as well. And next certificate is for Professor Veena Jain for chairing a session today. Thank you, Veena. And Swati, thank you for chairing the session. And now we have recorded this picture and we'll put it. Is it okay, Peter, if we can put it on YouTube or on our KGMU platform on the website? Can we post your lecture?
Yeah, that's fine on KGMU, right? Yeah, all the patients had their eyes blanked out, so I think that's all okay. So yeah,
Okay,
yeah.
so that will go there. Thank you so much for joining in. Over to you.
Thank you very much. Thanks for the opportunity. Nice to see you all.
Thanks, sir.
Thanks, Doc.
Thank you, ma'am.
Bye now. Take
Bye.
care.
Thank you. Bye.